I'd like to introduce our guest speaker, Dr. Stephen L. Dewey. Dr. Dewey is a regular guy, although his qualifications would enable him to be in any academic setting anywhere in the world. He received his PhD from the University of Iowa and completed a postdoctoral fellowship in the neurology department right here at Stony Brook. He worked for many years at Brookhaven National Lab, conducting research on the effects of addictive drugs on the human brain, which is the subject of the talk tonight. His studies led to the development of an effective treatment for addiction. He moved on to other venues, including Feinstein Institute for Medical Research, where he is no longer. He had been there almost 10 years. He has moved on to the Department of Psychiatry at New York University School of Medicine. He started an outreach program in 1994 to school districts throughout Long Island and the tri-state area, and his message has reached hundreds of thousands of children, parents, teachers, administrators, and counselors. It's science-based, as you will see, objective, and very, very good to hear. I don't think you'll be bored for a second. Dr. Dewey recently accepted an appointment to the Suffolk County Board of Health, where he's continuing his education efforts in the fight against drug abuse. He is also Director of Research Education at Seafield Center. He's been featured on almost every single network, both national and local, as well as the New York Times, the Wall Street Journal, and Newsday, and is the recipient of many, many honors and awards, including a Department of Energy's Distinguished Research and Development Award, the Brookhaven Award for Distinguished Effort in Community Service, Man of the Year in Science, Man of the Year in Education, Officer John Jansen Memorial Award for Prevention, Karen's Community Service Award, and its Research Award twice, and he's recently received LICAD's Community Champion Award. Ladies and gentlemen, boys and girls, please welcome Dr. Stephen Dewey.
Well, it's really nice to be here. I want to just make sure, for a million reasons, but I'm no longer at Feinstein. I just want to make sure that everyone's clear on that. I was at Feinstein for about 9 years, but I left, so I'm not there anymore. I'm not a scientist at Feinstein. I'm now at NYU and Seafield. I had the opportunity this week to talk to many of your kids, and we had a really good time. I'm a scientist by education. I grew up on I went to Port Jeff High School and college in New Jersey and medical school in the Midwest. And then I came back here, and I've always been interested in the effects of addictive drugs on the human brain for a whole bunch of reasons. So I've kind of dedicated my career to that. And I was president of my board of ed a long time ago, and it occurred to me that I probably should be bringing the science I do to kids. I mean, the science I do, I publish in manuscripts, and my scientific colleagues read them, and that's one way to disseminate information. But I really needed to get the message to kids because, after all, this is what my science impacts kids. So I started an outreach program where I just been going to schools, talking to kids about the research. I'm obviously really laid back, so I'll do the same thing with you that I did with your kids. If you have questions as we go through this, you don't have to wait to the end. Raise your hand and ask. I'll do my best to answer. I've been doing this for almost 40 years. So you can ask anything you want to ask. If I know the answer, I'll tell you, and if I don't, I'll tell you that too. So I have 2 kids. I'll bring them into it just because I like to piss them off. So I'll bring them in for a little bit. They're grown now, but an interesting thing happened this past Christmas, which kind of speaks to something that we're doing now. So I just want to show you some science. All the science you're going to see has been peer-reviewed and published. You can Google it. You can read the papers if you want. I'm not showing you anything that hasn't been published, that hasn't gone. Yeah.
I'm sorry. Hold the microphone a little closer.
Sure. Okay. Yeah, let me know if you can't hear. Okay, so the science I do is in the field of substance abuse. We do clinical work and we do preclinical work. That means we do stuff in small animals where we're developing new treatments. We developed a treatment many years ago that's now in clinical trials. And we do clinical work where we actually see people who are substance abusers and we scan their brain. People ask the age group of our patient population. Our youngest patients have been 9 years old, fourth graders, and our oldest patients are in their 80s. We've seen people abusing methamphetamine in their 80s. We've seen kids in fourth grade who are drinking alcohol. So this disease of addiction is one that impacts your lifespan. One of the things when I was in medical school I was impressed with was there are two things that predict treatment response to anything. One is the clinical plan, treatment. The second is education. People who are educated about their disease do better in the treatment of it. Well, we've been pretty good about educating people about diabetes and Alzheimer's disease and cancer, but we've been really kind of not good educating about addiction. And I think the reason of that is, this is not a shock to anybody, is because forever people haven't thought it was a disease. Right? People have thought that addiction is a choice, that people get addicted because they choose to get addicted. So we've been battling that. But over the years, because we've developed some new technologies, we can now see this disease in people before it expresses. So we have tools now that we can see changes in the brain of people that are consistent with unmasking this disease of addiction. And that's what I'll show you. And I'll show you what we've seen and some of the things we've learned about this disease. So, I told you that some patients are as young as 9, 10 years old. Kids getting drunk in their homes, breaking into homes, getting arrested. The point here is, and the reason I always bring up the age thing is because when I talk to high school kids, many of them are under the impression that this disease or getting addicted to something awaits, right? It's if they go off to college, it's if they start a job. The fact of the matter is, if you look at the data, now kids who are in 11th or 12th grade are actually on the old side, right? They're now they're now the older kids who are starting to express the disease. We're starting to see, and we'll talk about it, this whole thing with vaping that's going on is unmasking a lot of pathology. I'll show you exactly what I'm talking about and how it seems to be a predictor for subsequent drug abuse, but we'll talk about that. Okay, so the way we do the work we do is pretty simple. We image the human brain. These are 3 cameras, imaging cameras that are in every hospital. Everyone's heard of them, CT, X-ray, and MR. They're powerful techniques. They're important techniques. They tell us a lot about what's going on in the human body. But they're unique in that they are anatomical techniques. So if someone wants to see cancer in somebody's liver, you can see it with a CT. This is a young girl, her eyes are right here. This is an MRI scan. These little white spots are MS, multiple sclerosis, and a compound fracture of the forearm. The point here is that the imaging techniques that most people are familiar with are those that show anatomy. Well, if you think about a disease, any disease, they represent changes in physiology. They may ultimately represent a change in anatomy. When the disease progresses enough, there'll be an anatomical change that we can see. But diseases are really functional events, right? So in other words, we need a physiologic imaging technique, not an anatomical imaging technique. Well, the physiologic technique that we use is called PET, positron emission tomography. It was developed at Brookhaven National Lab in 1960. It's an imaging technique that takes advantage of some fundamental science in our bodies. Basically, to make it really simple, is energy metabolism. PET scans, ones that you're going to see tonight, many of them, represent changes in how your body is living as a consequence of metabolism, sugar metabolism. So the way you read a PET scan is pretty simple. You're just looking at the colors. Remember, colors of the rainbow, Roy G. Biv. Red represents one extreme, violet the other. So when we look at a human brain, this is a 21-year-old individual, his eyes are right up here. You're looking at the colors, single slice of the human brain. Areas of red is where the brain is very, very active. Yellows and greens, less active. Violets, not active at all. So it's really simple. If I put you in a PET scanner, and I put a tennis ball in your left hand, and I have you squeeze that tennis ball while I scan you, at the end of that scan, I'm going to see a bright metabolic spot, bright red spot, over that part of your brain that runs your left hand. So it's a simple, it's no more complicated than that. The beauty of this technique, though, is it allows us to see how the brain lives in response to all kinds of things. We can have you move, we can, touch the bottom of your foot and see how where your brain senses sensation. So we can do a lot of things. We can make you anxious, right? So we do that. We do a lot of things with pain. We put you in pain. The classic pain model that we used to use was putting your hand in a bucket of ice water. If you put your hand in a bucket of ice water, it hurts. Well, if it hurts, we can see pain in your brain, right? So these are the kinds of things that we do. These are the kinds of things that we have access to. We're able to set up protocols that allow us to look at anticipation, fear, pain, all kinds of things. Motor movements. We can look at kids who are dyslexic. We can look at people have looked at kids who are better in math than other kids, right? So you can get a whole sense of what's going on in the brain, because it's a really powerful technique. Where you'll probably run into it most commonly is in cancer. It's the number one diagnostic imaging technique for cancer, because how do we diagnose cancer? Usually one of two ways. We feel a mass or we become symptomatic of one. Well, by the time you feel a mass or you're symptomatic of a mass, that means the cancer is grown. But PET scanning allows us to see cancer when it's much sooner, right? Because it's changes in metabolic rate. So we can see cancer in many cases, before people become symptomatic. That begs the obvious question: why would I go have a PET scan if I don't feel anything and I don't have any symptoms? Well, there's a huge push in genetics. What if your mom had breast cancer? What if your dad had prostate cancer? What if there's colon cancer, right? So it's a really powerful technique. And it also allows us to look at the efficacy of treatment. So in many cancers, we give chemotherapy or radiation, and then we watch to see if the tumor gets bigger or smaller over some period of time. With PET scanning, we can actually see if the metabolic rate, how the cancer is growing, is affected by the treatment plan. So it's a really powerful tool, and we use it most commonly in the clinical realm for cancer. But we use it in the CNS, the brain, to look at things like Alzheimer's disease and Huntington's disease, and my interest happens to be addiction. So 3 PET scans, 3 very different PET scans in 3 very normal people. Just gives you a sense that PET scans can be different in people who are completely normal. This is a 5-day-old baby. There isn't anyone in this, contrary to what I hear, there isn't anyone in this room who can remember being 5 days old. I know I have kids tell me all the time, I remember being born, it was dark, and then it was light, and I remember the light, right? I mean, I hear this stuff all the time. If you can remember being born, we need you for a PET scan, because we got to take a look, right? No one can remember being born, no one can remember being 5 days old, because you really don't have the metabolic machinery in your brain that allows you to restore a memory. This is a 6-year-old boy, eyes are right on top, consistent with what we know about 6-year-olds. If you've ever seen a 6-year-old or remember your kids at 6, they're a nightmare, right? They're a nightmare. Mine were. They picked on each other, they pulled the dog's tail, right? They do what 6-year-olds do. Their brains are very, very active. This is what we have to look forward to. This is us in our 30s. You can see as we age, our metabolic rate decreases. That's normal. That's a normal process. If it makes you feel better, to think of it like this guy can do a lot more with his brain than this 6-year-old can. So one way to look at it is we become more efficient, right? We don't need near the energy in our brain that a 6-year-old has, and we can do more. The point here is that our brains change with age. And in my business, that becomes very important, because when I'm looking at a 12-year-old who's abusing methamphetamine, I have to compare it to a 12-year-old who isn't. I can't compare a 12-year-old to a 30-year-old, because age alone produces a huge change. So, all the images you're going to see tonight are scanned against or compared to age-matched controls. Because again, when I look at a 15-year-old, I can't compare him or her to a 20-year-old, because there's a change in age alone. Okay, so we're going to make some really simple statements about this disease of addiction that we've been dealing with. And for the most part, it's predicated on or based on a change in a chemical in your brain called dopamine. Everybody has this chemical in your brain makes it, I can't give it to you, I can't put it in a pill, I can't put it in a cup, can't put it in a syringe. The dopamine that's in your brain makes. And its primary role is movement. Whenever you move, your brain has to make and release dopamine to allow that to happen. So movement is the primary role for dopamine in the human brain. When you lose dopamine, consistent with that, you have issues with movement. Well, so the most common disease associated with decreases in brain dopamine is Parkinson's. If you've ever seen a Parkinson's patient, Muhammad Ali is the one the kids all know. Towards the end of his life, he couldn't even speak. It's a disease characterized by changes in movement, the consequence are resulting from a decrease in brain dopamine. So dopamine's primary role is movement. It does something else. It's the neurotransmitter that we associate with the ability to feel happy and sad, or sad. So just to make this simple, I told your kids the other day, if they left the room they were in and they went to their next class and the teacher gave them a 95 on a math test, their dopamine would go up. It'd go up about 5 or 6%. We can measure it in a PET scan and we can see how much. So a natural reward, whatever that is, 100 on a math test, being with your spouse, being with your kids, Friday afternoon, going to the beach, whatever. I'm a Patriots fan. I was bummed when they lost. Some of my dopamine went down, but the year before they won, so it went up. A natural reward will raise your brain dopamine 5 or 6%. Every addictive drug that we've ever studied works by raising brain dopamine. That's how they work. You take an addictive drug and dopamine levels go up, period. Now, perspective. So the kid who goes to his math class and gets a 95 on it, his dopamine or her dopamine goes up 5 or 6%. The kid decides he's going to celebrate by going across the street and using methamphetamine. Methamphetamine is in every school district on Long Island. It's the chemical, for those of you who don't know, that the guy was making in Breaking Bad. That's methamphetamine. So the kid gets a 95 on a test, it goes up 5 or 6%. He walks across the street, takes some methamphetamine to celebrate, and his dopamine levels will go up between 950,000 and 1.2 million%. So that just gives you a sense of what we're up against. Addictive drugs raise brain dopamine hundreds of thousands of times greater than anything they will do naturally. Now we can take it to the next step. The degree to which a drug raises dopamine tells us how addictive it is. A drug that raises it 1.2 million is far more addictive than caffeine, which will raise it 100%. So caffeine, addictive drug, raises brain dopamine about 100, 120%, not nearly as addictive as meth. Opiates, 400 to 800,000, cocaine, 200 to 500,000. So you kind of get a sense, alcohol, 50,000, 60,000, pot, 100, 120,000. Right, so we get this sense of the addictive liability of a drug is related to the magnitude of its effect on brain dopamine. Every addictive drug works by raising brain dopamine. Okay, so the question becomes obvious. Why do some kids abuse drugs and some kids don't? So forever, we've been going to schools and places around the U.S. asking a simple question to kids. How many of you will try anything once? People raise their hands. And how many of you won't? And people raise their hands. You know these kids, the kids who will try anything once, not just chemical substances, but they're the kids who want to go on the highest, the fastest roller coaster. They want to bungee jump. They want to hang glide. They want to parachute, bungee jump out of hot air balloons. You know these kids. They call themselves adrenaline junkies. And we have the kids who say they won't. Well, okay, so we scan them both. And in these scans, we're actually looking at brain dopamine. We use a compound called raclopride. We can look at brain dopamine, get a measurement of how much you have. And lo and behold, what we found was pretty striking. These are two kids, eyes are right on the top. These PET scans are now measuring brain dopamine. These are not metabolic scans. They're actually measuring the concentration of dopamine in your brain. And what we found was in a normal individual, we get a normal level based on their age. The kids who self-report novelty-seeking behavior, that is, they want to try something novel, bungee jump, whatever it is. Lo and behold, their brain dopamine is a little bit higher than normal controls. So it was an interesting data set. It was certainly consistent. We had evidence now that would suggest some kids have a little more dopamine than others. The manifestation of that tends to be a kid who says he wants to try something novel versus a kid who doesn't. Well, so we didn't really know if it meant anything, if it was insignificant, so we did the obvious thing. We challenged them both. We gave both groups of kids a shot glass of alcohol, and they drank it. And the kid on the left, who's got a normal dopamine level and who self-reports an unwillingness to try anything novel beyond the obvious, his brain dopamine goes up about 950%, which is consistent with the dose of alcohol based on the kid's weight. This kid, it goes up about 34,000%. So lo and behold, not only do we have a difference in the two kids, which you can't tell apart if you look at them, but a neurochemical difference that we can see with a PET scan that has a consequence. The consequence is if they take an addictive drug, a drug that specifically targets that system, if they have a little too much dopamine, they'll have an altered response. Well, that's consistent with what we know. You talk to kids who drink alcohol, some kids like it and some kids don't. And some kids really like it and some kids like it a little bit. So this was our first insight into this disease that says some kids have a brain dopamine system that will have an altered response to an addictive substance unbeknownst to them. So the kid takes, you know this, I lived with 6 guys in college. 2 of them are alcoholics today. Everybody drank, but only 2 became alcoholics. So you have kids who responded to alcohol differently. Well, that was consistent. It certainly was reproducible. So the next thing we did was we thought, wow, this is really compelling. This says something about the disease nature of addiction. This is a real change. This is an organic change in a brain chemical. Well, we know other diseases of the CNS are the same thing. Parkinson's disease is one, Alzheimer's is, schizophrenia is, Huntington's chorea is, depression is, bipolar disorder is. So it's not striking that it's a neurotransmitter difference, but we now know which one it is, and we can see it. Well, so then the epidemiologists got at it, and they looked at the data set, and they said, well, the incidence of addiction across the United States is about 14%. That means 86% of the population doesn't have it. Well, in a perfect world, what we would say, we would find that there was about 14% of the kids who had this condition. Well, unfortunately, that wasn't the case. It's about 7%. So what we found was kind of like half of them. So the question came up, where's the other half? We got kids who have a little too much dopamine, they'll have an altered response to an addictive substance that specifically targets it. The other half is right here. This is the exact opposite. Again, eyes are right on here, normal dopamine, bilaterally symmetrical, and it doesn't matter where it is, but here you see dopamine. Here are kids that have ADD or ADHD. Lo and behold, their brain dopamine is low. It's low by about 5%. Well, so there we go, same thing. Now we've got kids who have a little too little dopamine. Let's challenge them. Sure enough, same thing happens. 950% increase here, 34,000 and change here. Well, so now the story becomes a little more complete. It's not just too much dopamine, it's an altered system. Either a little too much or a little too little. The manifestation of a little too much is the kid who will do anything once. The manifestation of a little too little is the kid with ADD or ADHD. Well, so that's consistent with what we know. The system exists on both ends of the scales. There are behavioral components of each. We know that if we medicate this kid, if we give them Ritalin or some drug that we use to bring dopamine levels back to normal, and then we do the alcohol challenge, we get a 950% here and a 950% here, which means kids who are treated for ADD or ADHD and get their dopamine levels back to their age-matched levels, they will have a normal response to alcohol. Well, so that says something that's really important. That says that treating the disease, treating ADHD, actually removes the risk, lowers the risk of the expression of the disease of addiction. Well, so that was an interesting data set. Now we take it a step further. We find that the kids who are the highest risk of unmasking the disease of addiction are the kids who have this disorder and who are not treated for it. So the kid who's got ADD or ADHD who doesn't get medication, what do? They self-medicate. They go and they drink, or they go and they start smoking pot to self-medicate the pre-existing condition. Well, we know from the data that's out there that it's estimated that 2/3 of people with the disease of addiction have it because they self-medicated another comorbid disease. Here it is. So now the data is pretty complete. The story's pretty simple. We have a really good understanding of what it is. We know that most kids with ADD or ADHD outgrow it. So, one of the problems is kids who are on the medication for ADD or ADHD, they go away to college or they leave the home and they go to start living on their own. The disease goes away on its own, 18, 19, 20 years old, but they continue to take the medication. Now you're taking a medication to raise brain dopamine in a system that's already normal. Well, so what does that do? So I go and visit my daughter in college several years ago. This is what I do for a living, and I go down there to see her, and she's got the guts with her she lived with 8 girls, to have a bottle of Adderall on the kitchen table that they were taking for studying for tests. I know. So one of the big problems, the other big problem we have is people who don't have the disease of ADD or ADHD, but who are medicated for it. Well, that's a normal dopamine system into which you're putting a drug that's raising it. So the risk is kids who don't have the disease but take Ritalin or a Ritalin-like drug, or kids who have the disease and don't get treated. They then self-medicate. So the story's pretty complete. The story's pretty reproducible. We can look at all kinds of things about the right medication, how you remove the risk. We can look at what happens in kids who don't get treated. They self-medicate. The disease becomes pretty apparent and pretty obvious. One of the ways to look at this is, depending on what paper you read or what data set you look at, it's estimated that 3/4 of diabetics have the disease of diabetes that unmasks when they gain too much weight. Now, we've all been down this road where you go to your physician and your A1C or your blood glucose is 150 and they say, drop 20 pounds. And you drop 20 pounds and your blood glucose goes back to normal. It simply means the disease of diabetes unmasks when you become too heavy. Well, fortunately, it's a manageable disease. You lose a little weight. Unfortunately, with addiction, it's a disease that unmasks when you use an addictive substance, and it doesn't go away when you lose weight. Now it becomes a disease we need to manage. So, this is what goes on. Here's a kid who's got ADD, low brain dopamine, drinks alcohol, brings his dopamine levels back to normal. We see this time and time again. You talk to kids who have ADD or ADHD who are not self-medicated, they feel better when they drink, they feel better when they smoke pot. So, we now have a pretty good understanding of what the disease is. We know where to look. We know what to look for. We know when to look for it. We have a good understanding of the numbers because the beauty of PET is it's quantitative. It's not just, I'm showing you this being more red than that, but PET is real numbers. If I showed you data tables, you'd all fall asleep. So I'm showing you pretty pictures of reds, right? So PET is a quantitative thing. We actually get the numbers, the amount of dopamine in the brain in response to it. Okay. So the next question became pretty obvious. When I was in medical school a long time ago, medical school is 4 years. In my hospital, 3 kids died in the early 80s from substance abuse. 3 kids in 4 years, that's less than a kid a year. Today, in 2018, we're losing 7 kids an hour. Every hour of every day, 7 kids die from drug abuse. It is the greatest risk to your kids in high school, and mine, in high schools. Used to be handguns, used to be car accidents, used to be home accidents. Now it's substance abuse. The greatest risk to your kids in middle school and high school is a drug overdose. 7 kids an hour. So that begs the question, what the hell's going on, right? So we have groups of people looking at it. Is it global warming? Is it, comets? Is it Trump? I don't know what it is, right? So people are looking. Is there anything that's correlating? And this isn't going to be a surprise to anybody. The greatest correlation is this, the internet. We know from a whole host of studies, and you can read them to your heart's content, that the internet is an addictive behavior, right? We know that kids meet all the criteria for addiction to the internet. We know from studies that have been published where people live in the United States, use the internet, move away to other countries where the internet is limited, and they go through, become psychotic, first break, all kinds of things go on. So it's no surprise. It's no surprise that kids get addicted to the internet. The question is always the simple one, does internet addiction cause chemical dependency? The data's not there yet. When I was in medical school, I was always told that pot was the gateway drug. If you smoke pot today, by the end of the week, you're going to be using cocaine. If you look at the data, that just wasn't true. Pot never looks to be a gateway drug. Gateway meaning if you look to see what's the greatest predictor of subsequent drug abuse, it's not pot. If you really want to look at gateway drugs, you look at the inhalants. Right? So kids in elementary schools, sniffing glue, to the people my age, remember sniffing glue? It used to be big in the 60s. Well, now what kids sniff is Sharpies, right? Everybody knows that. Kids are stealing Sharpies. Ask anyone in an elementary school. You steal a couple of Sharpies, put them in a plastic bag, smell them, you get high. Those are the greatest predictors of subsequent drug abuse, are kids who are using inhalants in elementary school. So this is a data set that's pretty reproducible again. The internet addiction, talk to your kids. I talk to them every day. Kids get hooked on the internet. Well, so the question is, does one cause the other? The data's not there yet. There's a strong correlation. We certainly know that once you're addicted to something, getting addicted to something else is easier. But does one cause the other? The data just aren't there. But this past Christmas, my 2 kids came home. They live in the South. Well, my son lives in New York, but my daughter's in the South. They came home for Christmas. And we were sitting around the kitchen table, the 4 of us having dinner. And my son passed my daughter, I don't know, potatoes. I don't know what the hell it was. Passed her something. And it struck me as odd because we weren't talking. Well, it turns out she texted him to pass the potatoes. Right? So these are 2 kids, siblings, brothers and sisters, 25 and 28, sitting 3 feet from each other, texting each other. I mean, what the hell's going on, right? So we were I've been really interested in cell phone addiction. You can talk to your kids about this, ask them. Adults too, it's not just kids. We know that kids get addicted to their cell phones. It's simple. Studies have been done where you could put a kid in a PET scanner, get a baseline dopamine measurement, hand him a cell phone, and his dopamine levels will go up 120,000%. It's not a mystery, it's not a surprise. Kids get addicted to their cell phones. The question here is, does it cause chemical dependency? The data there are stronger, but they're not there yet. So we know that cell phones are an issue. I was in your district 3 days ago. Every kid's got a cell phone, right? They were actually great. They didn't take them out, but cell phone addiction is something we're really interested in looking at because it's so common. And of course, there are lots of papers being published looking at cell phone addiction. What happens when you take the cell phone away from a kid? There are great studies, again, where people have moved within the U.S. from places where cell phone connectivity is 24/7 to places in the West where there's one cell tower every 500 miles, where there is no cells. And what happens to these kids, what they self-report. So, the first chemical we decided to look at made a lot of sense. It's the #1 drug of abuse in the world today, caffeine. It's not a surprise. There's no mystery here. We know that kids get exposed to caffeine. They get exposed to caffeine through drinks and through chocolate. So we just decided to look at what happens in the brains when you use caffeine. So we did a whole bunch of studies with hundreds and hundreds of people where we brought them in, got a baseline scan, and then gave them Monster. You all know what Monster is? Monster is that black can with 3 green lines. It's kind of like Red Bull, but it's a big can. The kids all know what it is. So, the first thing we did was to look at a very important question, which is the #1 cause of relapse. We took advantage of caffeine as the #1 drug of abuse to look at relapse. The #1 cause of relapse to drug-seeking behavior are environmental cues. Well, when you say that, you can imagine. When you say it to a bunch of 10th graders, it's like, what does that mean? So what we did was we went out and we got 40 people, brought them to the imaging center, various ages. They were going to be our controls, right? No history of drug abuse. But if I have a 21-year-old heroin abuser, I need a 21-year-old normal control. So they're my controls. They signed informed consent for controls. The only requirement I had was they had to like coffee. So I brought them to my imaging center, put them in the scanner. They were all going to be in normal controls. When the scan started, I brewed a pot of coffee in the next room. So I've got 40 people being scanned, and during the scan, I'm going to cue them to something they like, caffeine. They don't know about it, but all of a sudden they can smell coffee. This is what we get. These are all their brains added up, all 40 brains. This is a sagittal view of the human brain, so you're looking at it like this. This is a coronal view. Everybody's looking at you. Transaxial, eyes are here, feet are into the board. Upon the cue, 2 parts of their brain activate, and only 2 parts. You see one spot here because it's only half the brain. It's called your nucleus accumbens. It's the part of your brain, you use it every day, that makes you get things you have to have. So if you've ever been thirsty, it turns on and tells you to get water. If you're hungry, it turns on and tells you to get food. If you're in a place that isn't safe, it turns on and tells you to seek safety. So it's evolutionarily the oldest part of your brain because it's the part of your brain that keeps you going, it keeps you fed, hydrated, and safe. Well, look what happens in the drug abuse world. Whenever you use an addictive substance that produces this enormous increase in brain dopamine, your brain encodes all the information about the environment you're in and stores it with the effect of the drug. And anytime you re-experience any part of that environment, your accumbens turns on and tells you to get the drug associated with the cue. So what does that mean? That means what do I hear the most? The thing I hear the most is music. Kids get high listening to Justin Bieber, whatever. Okay. I know. Can you imagine? I know. I hear it. They get high listening to Justin Bieber, and a week later they hear Justin Bieber. There's your cue. They get high with their friend, and 4 days later they run into their friend. There's the cue. They get high in their basement. They get high in a car. They get high in a beach. The number one thing, ask them. When people smoke, they crave when they're on the phone. They crave after a meal. They crave when they're driving a car. These are all cued events that cause relapse. Kids are cued, not just kids, all of us get cued by the environment we're in when we use and when we experience or re-experience any part of that environment, this turns on. So it'll give you a little bit of perspective of this just say no thing. It's a little more complicated. I mean, just imagine, the comparison is if you're thirsty, don't get a drink. Well, you can not get a drink for a while. Eventually you're going to get a drink because the cue is so strong. It's such a motivating thing. So it gives us insight into what a cue is and how it plays such an important role in the disease of addiction. So here's our study. Bring a bunch of people in, get a baseline PET scan. Give them 1 can of Monster. They have 30 minutes to drink it. And here's their brain. No big surprise. I have coffee every morning because I have a 2-hour commute on the LIE, and I want my brain to be like this at exit 49, not like this, right? So we know if you drink coffee, your brain activates. It's not a surprise. It's certainly consistent. It's dose dependent, and it's not a surprise. Now, the magnitude of the effect was, this is okay if you're 6 years old. It's not okay if you're 18. This is a huge effect. But anyway, it's a predictable effect. What wasn't predictable was the time course. We brought everybody back the next day and scanned them. And their brain was just like this. So here's the deal with caffeine. Caffeine will produce a huge increase in metabolic rate, higher than anything you'll do naturally. And that effect will last for 24 to 36 hours. Now, if you think about it, it's pretty simple. I have my coffee in the morning. By the time I get to work at 8:30, I'm ready for a nap. But my brain is like this. Well, so that tells us something that's really important, and that is, with every addictive drug out there, they will change your brain for a lot longer than they will change how you feel. Makes perfect sense. You talk to people who have used drugs, they get high, then they're no longer high, they use again. The disease of addiction gets unmasked when you introduce an addictive substance to a brain that's already been changed by one. So when the kid uses a drug, gets an increase in brain dopamine, it drops, they no longer feel the effect, they use again. Well, the brain is still changed. They don't feel the brain changed, but the chemistry is still different. So this disease is one that unmasks when you use in a brain already changed. So this was pretty interesting. We had this effect, certainly dose dependent, and absolutely time dependent. That means if you drink a cup of coffee Monday morning, by Tuesday afternoon, your brain is still changed. Well, something else goes on. When your brain is this active, there's something around your brain called the blood-brain barrier. You can think of it as a fence. It's a very special, fancy fence that keeps drugs out. When you get your brain this active, that fence starts to fail. The data shows that the blood-brain barrier starts to leak when metabolic rates are really high. So what does that mean? That means if you caffeinate your brain, and then when it's changed as a consequence of caffeine, you introduce another addictive substance, that other addictive substance becomes more addictive. So caffeine facilitates the addictive liability of other drugs. Well, they took advantage of that, and they made this stuff. You can ask your kids what it is. Everybody knows. Four Loko is caffeinated alcohol. And the reason they made it, one of the big reasons they made it, is because you can consume less of it and get more intoxicated because the caffeine opens the blood-brain barrier, more alcohol gets in. The number one mixed drink in New York City is Red Bull and vodka. Because, again, caffeine introduced to the brain makes anything else more addictive. But just look at the behavior. People who drink coffee, a lot of them smoke. People who drink alcohol, drink coffee. Caffeine changes the blood-brain barrier, which alters the delivery of other addictive drugs. One of the things that we always tell kids, because they say it to me, I don't have to worry about it because I don't drink coffee on the weekends. I'll drink coffee Monday through Friday, but I don't drink coffee on the weekends, so I don't have to worry about it. Well, you drink coffee on Friday, your brain is still changed Saturday. So if you drink coffee Friday and you go out drinking Saturday night, caffeine is still facilitating the process. So, next we looked at tobacco. Everybody knows the deal with tobacco. The kids will tell you exactly what they know. You ask kids why they smoke. If the ones who do, they'll tell you the risk of cancer is small. It's true, only 7%. They know all this stuff, but we know 450,000 people die a year, 50,000 from secondhand smoke, so we know all this stuff, and so do the kids. The question is, what does smoking do to the human brain? So this is a series of studies we did that looked exactly at that question. These are two 21-year-old women. Eyes are on the top. This is a normal control non-smoker. In the center of her brain is a chemical called monoamine oxidase. We all have it. Unless you consume tobacco. If you consume a tobacco product, you destroy the monoamine oxidase in your brain, period. Not some of you, not half of you, all of you. It's a binary event. Smoke, consume tobacco, and you'll destroy monoamine oxidase. Whether it's a cigarette, a hookah, chewing tobacco, cigar, pipe, doesn't matter. If you are consuming a tobacco product, you will lose monoamine oxidase in your brain. If you are exposed to secondhand smoke, and we all have that, you lose it too. So, this is an event. It's very simple. It's dose dependent. The person smoking loses it faster and more of it than the kid sitting next to him, but the kid sitting next to him loses it. It's a reversible process. It's the only one you'll see tonight that's reversible. That means if you quit smoking, it comes back. It takes about 55 days, but it comes back. So it's a reversible process. If you smoke for a week and quit, it comes back. If you smoke for 50 years and quit, it comes back. But it's a dose-dependent effect. This is a kid who's never smoked. Here's his MAO. 1 puff, 3 puffs, 1 cigarette, 3 cigarettes. You can see as well as I can that it is a specific effect on a specific chemical in your brain. Now the question is, what does that chemical do? Well, I told you that whenever you want to move, you have to release dopamine to allow the muscles to move my fingers. Well, I got to have a mechanism that gets rid of it as fast as it makes it, because I got to be able to stop as quickly as I start. This is the chemical that gets rid of dopamine. So if you don't have it, what does that mean? That means every time you take another addictive substance, the effect is bigger and longer lasting. Well, so, okay, not a surprise, just look at the epidemiology. People who smoke have a higher incidence of addiction to other drugs. Well, but there's something that's a little more insidious about this. Remember what separated the kid who said he'll try anything once from the kid who said he wouldn't. The kid who will try anything once has a dopamine system that's about 5% higher than the other kid. Well, so what does that mean? That means if you take a bunch of kids who say they will not try, they're not interested in trying anything once, they're our normal controls. and I expose them to secondhand smoke. In about 30 minutes, they start losing their MAO. In about 90 minutes, their dopamine levels start to rise as a consequence. And all of a sudden, they've got about 5% more dopamine than when they walked in. So now we have the data that answers the age-old question that I hear all the time. I don't know why the hell I did it. Why did you ecstasy? I don't know. I went to a party, was there for a while, and I thought, what the hell, give it a try. We now know that secondhand smoke, exposure to secondhand smoke, produces this change in monoamine oxidase, specifically and exclusively, that loss of brain MAO causes an increase in brain dopamine that can change kids' behavior. So we know that exposure to secondhand smoke increases the likelihood that individuals will try something they normally wouldn't. Well, so that became a big problem, right? You can imagine when all these data started to come out, we need to start thinking about kids getting exposed to secondhand smoke and smoking at parties. So what did they do? They came up with this. So vaping, and all the kids, usually this is when the kids applaud. So they came up with vaping is old, it's old, it's not, it's been around forever. But in terms of my business and the substance abuse world, we've never seen anything take off as fast as vaping as a route of administration. Nothing comes close. Kids are vaping in 5th, 6th, and 7th grade. It is the greatest predictor of subsequent drug abuse, greater than anything we've ever seen. And it's based on a very simple fact that if you can get people to vape nicotine as opposed to smoke tobacco, they won't lose MAO. And it's absolutely true. Vaping, if you vape nicotine, you won't lose MAO. It's not nicotine that's killing MAO, it's 3 compounds in tobacco leaves themselves. So vaping was a way to circumvent the MAO effect. And it's consistent with what we know about the whole treatment world. In the 60s, we developed the use of the drug methadone for heroin treatment, right, for heroin addiction, based on a simple process. You're going to use heroin, that's an illegal drug that you're going to have to do whatever you have to do to get it. How about we give you methadone that's made safely, that's made dose dependently, that we're going to watch you administer in the right way and the right dose? So it's called a replacement strategy. Well, vaping nicotine is no different than that. It's a replacement strategy. It's no different than the patch, than the gum, than the inhalers. The problem is the obvious. We now know a lot more about vaping, and we have a lot more sensitive tools to look at the consequences. I think everybody knows what vaping is. It's nothing more than taking a liquid that's usually at room temperature, exposing it to a heated element. That heated element causes that liquid to vaporize. You breathe in the vapor. Everybody knows what kids are using. You've heard of juuling. If you haven't heard of juuling, this is what juuling is. Ask your kids. Juul is just a device that looks like a USB drive. In fact, the first time I saw one, that's what I thought it was. Or an e-cigarette. These are really common. Juuling, kids get them on Amazon. I mean, you know all the stuff. Okay, so and they look like this. They come in a whole bunch of different colors. You can get the liquids at Amazon, and that's what kids use. So the prevalence has taken us by surprise. In 2015, the amount of kids vaping was 3 times less than it is today. It is increased faster than anything we have ever seen in terms of a route of administration. One of the things that's disturbing about it is the single greatest predictor of further substance abuse or unmasking addiction. It is the greatest predictor of kids who will go on to use something else. More so than Sharpies, more so than Whiteout, more so than Whippets, nitrous oxide. It is the greatest threat that we've ever seen for subsequent drug abuse, kids who are vaping. Now, 5 or 6 years ago, we didn't have the ability to see nanoparticles. Nanoparticles are just small particles, 10 to the minus 9. They're really tiny. What we know about vaping is very simple. Whenever you introduce a liquid, it can be Poland Springs water, to a heated metal element, pieces of the metal come off in the vape. They come off in the forms of nanoparticles, which are just tiny particles. It's no different than if you take a stainless steel pot in your kitchen, fill it with tap water, put it on the stove and boil it. The water that's coming off, the steam that's coming off, if you stick your face in it and you don't burn yourself, you're going to breathe in nanoparticles of the stainless pot. It's not a surprise. It's no mystery. It's physics. The thing is, we can see it. And the thing that's even more disconcerting is the metal that the elements are made of. Nickel, chromium, and cadmium. So kids who are vaping are getting huge concentrations. You just saw it 2 nights ago, and the ABC World News released Johns Hopkins' big report on the concentration of nanoparticles in kids who are vaping. They're getting large concentrations of nickel, chromium, and cadmium in their lungs from vaping. Now, if you go and look at the OSHA website, which is the website that lists all the carcinogen and toxicity of chemicals, when you look at the metals that are carcinogenic, number 1 is lead, number 3 is cadmium. So, what the kids think is that it's safe. What the kids think is that it's steam. That's what I hear every day. It's steam. It's like going into a sauna. Any sauna I've ever gone in, which aren't many, obviously, it's water poured over hot rocks. It's not water poured over some heated red metal coil. So what the kids think they're getting is steam. Well, if you go look at the liquid, the juices, just look at the bottle. It's only 10% water. It's 90% propylene glycol. So what the kids are getting that they think is steam is vaporized propylene glycol. Propylene glycol is the compound used to de-ice plane wings. So you can go out and you can Google propylene glycol and you'll find 500,000 articles that say, fill your swimming pool with it, it's safe. And you'll find 500,000 articles that say it's going to give you brain cancer and seizures, which simply means the jury's out. But the thing we need to impress upon the kids is it's not just steam. In fact, it's very little steam. It's actually vaporized propylene glycol with nanoparticles of the metal in it. Back in the 70s, there was a disease that was reported, was fatal, called popcorn lung. And the name came from the company that made microwave buttered popcorn. And they used a compound called diacetyl to help make the butter flavoring in the popcorn. Diacetyl caused a fatal lung disease that killed about 140 people. And it was called popcorn lung because it happened from the company of the people who were making microwaved popcorn. So the FDA, in their usual style, got around to it, and in the early 80s outlawed or banned diacetyl from popcorn, microwave popcorn. So the microwave popcorn you go buy today doesn't have it in it. Well, guess where it is? It's in the liquids for vapes. 39 out of 51 liquids that are sampled had diacetyl in it. So it's something to keep in mind. Kids can get popcorn lung. Popcorn lung is a fatal disease. It's consistent with diacetyl. The FDA will get around to getting it out of the liquids eventually, but it's not there yet. There were anecdotal reports that we were hearing for a long time that one of the things that we kept hearing about vaping was it's produced changes in vision. We would hear from kids that their vision changed. No one ever correlated it with anything. It was anecdotal, which kind of means rumor. But a year ago, the New England Journal released a publication that showed that in kids who vape nicotine, it's unique to nicotine-containing vapes. That what they add to that to make nicotine solvent is formaldehyde, tiny little concentrations of formaldehyde. Formaldehyde is a retinal toxic compound. It's a compound we use to embalm bodies after death, and it's retinal toxic. So now the data is no longer anecdotal. The science shows us that kids who are vaping nicotine are getting concentrations of formaldehyde, which end up in the retina, which causes changes in vision. So it's consistent with the anecdotal reports, and now the science shows it to us. Alcohol. So everybody knows what's going on with alcohol. Kids know, every kid knows what these are. They didn't know that this was my daughter's roommate in college, which doing the beer funnel, shotgun. I live out on the East End. Keg stands are really popular. When my son was in high school, he told me he didn't drink after all this. I'm in the business. Son of a bitch is in this picture. I got off his computer, playing beer pong. So, right, everybody knows beer pong. Everyone knows different routes of administration, right? In the last 7 years, the greatest increase we've seen in alcohol consumption is this. It's called eyeballing. It's now the #1 drinking game across the United States. It's exactly what you think it is. It's kids taking typically clear alcohol, gin or vodka. They take the top off the bottle, put their eye on it, and tip it up. It's really simple. Our eyes are nothing more than spheres, balls full of water. The alcohol readily exchanges with the water, and all of a sudden your orbit's full of your eyes full of alcohol. It's a game, back in the old days, in my time, the drinking game. Anyone remember quarters? I say quarters, and they're like, what? Quarters, or the classic fraternity or sorority game. You threw a couple of kids in the trunk of a car with 3 bottles of Jack Daniels, slam the trunk lid and say, we'll open it when they're gone. And 400 kids a year die from alcohol toxicity. I mean, we see it all the time. The drinking games have changed. This is now the #1 drinking game, and it's exactly what you think. When you put a bottle of alcohol in your eye, it burns. So the game is how long you can keep the bottle up. So it's done with a stopwatch or a watch. You can go to any school district and you can find out what the time is that people are trying to beat. 12 minutes, 10 minutes. It's exactly what you think it is. And it has the consequence that's exactly what you think it has. If you look at the data across the US, the estimate for the incidence of eyeballing is about 7,500% increase. Whenever you look at an incidence number, you have to take it with a grain of salt because that's predicated on kids self-reporting. In other words, are they telling the truth? So a number of 7,500 is as valid as we can think it is. The number that's really valid is looking at the number of cases of blindness. They're up about 212% across the US. Kids are losing their sight from eyeballing alcohol. Now, the thing that we know, it's pretty consistent because the specific gravity of alcohol is different than water. When you fill your eye with alcohol, you can't see through it. Kids rarely do both eyes because they don't want to not see. So the classic telltale sign, when my kids, I used to stay up all night till the kids came home, right? And they'd come home with 2 bloodshot eyes and they'd say, oh, smoke at the party, me being an idiot. Oh, yeah, well, that happens. Now when kids come home with 1 bloodshot eye, it's the classic sign that that's what they're doing. And they're doing it in every district. It's become so popular because if they go to a party and they drink alcohol and they get in a car and drive away and a cop pulls them over, the cop gives them a breathalyzer. Well, most of the signal from the breathalyzer comes from the alcohol that was in your mouth when you drank it. If you never put it in your mouth and instead put it in through your eye, it doesn't show up on the breathalyzer. So it's become a way to circumvent the breathalyzer. Coming up rapidly to that is this. And again, it's exactly what you think it is. Just to make sure that everyone we're on the same page, because I get this every time I show this slide. Guys always say to me, yeah, what figures, girls are fools. It's twice as common in boys as it is in girls. Right? It's really become very popular because we think the whole blindness thing is kind of getting, I hear it now a lot. I don't want to lose my sight. But the consequence of this is exactly what you think it is. In a female, it can render her sterile for the rest of her life, a single exposure. In a male, alcohol's a drying agent. It dries out the colon. When you dry out your colon, it tears. When your colon tears, you get sepsis. Sepsis is the #1 killer in hospitals, right? So this is what's going on. It's become very popular because it's very hard to detect. So let's take a look at the consequence of this. Vaping is quick for alcohol. The reason kids are vaping alcohol is because they get the fastest high in the shortest period of time. Remember, alcohol's vapor pressure is lower than water. So if you heat it with a little disposable lighter, it turns into a gas. So what they're doing is they're taking glass bottles full of alcohol, vodka or gin typically, put a paper cup over it, upside down, heat the bottom of the bottle. The alcohol vaporizes, fills the cup. They take the cup and they breathe in the alcohol. They can get a buzz between the 3 or 4 minutes between a changing period in a high school or in a day. What does it do to the brain? So here's our classic study looking at the effects of alcohol on the human brain. This is 2 levels of the human brain, about at the level of the eyes. So it's a slice like this, about at the level of the ears, a slice like this. This is a brain that's drunk. So sober, drunk. Pretty simple. If you want to think of it, make it easier, think of your brain that lives on a dimmer switch. Everyone knows what a dimmer switch is. When you drink caffeine, you slide the dimmer switch up. Brain becomes really active. When you drink alcohol, you drop it. So the metabolic rate drops. a considerable amount. This part of the brain shuts off. Cerebellum, primary role is balance. Makes sense when people are drunk, they don't balance well because this part of their brain is shut off. The most compelling part of this data set was the same thing as the compelling part of the caffeine data set, and that is time. The magnitude of the effect is predictable. It's dose dependent, it's sex independent, boys and girls. The more you drink, the greater the drop. What we didn't expect was the time course. Whereas caffeine took 24 to 36 hours to recover, this takes 5 to 7 days. So a single exposure to alcohol will lower your brain metabolism for about a week. Well, so what happens? Kids start out with a normal metabolic rate, they drink and it drops. And 5 to 7 days later, they recover, they drink again and it drops. 5 to 7 days later, recover. Now, if they drink and drop and they drink again within that 5 to 7 day, they're introducing a chemical substance to a brain already changed by one, the process starts. Well, after a while of doing this, that game ends. These are 3 52-year-old people. On the left is a normal control, eyes are on the top, normal PET scan. This is a 52-year-old male alcoholic who hasn't had a drink in over 20 years. What we now know about this disease of alcoholism is at some point in time, and that point in time is determined by the age of onset of drinking. The younger you are, the sooner you get there, and the pattern. If you binge drink, you'll get there faster than if you drink consistently each day. At some point in time, the brain says, that's it, I'm here. I'm never going back to here. This is my new metabolic state. I'm never going back unless I drink. This is a 52-year-old male alcoholic who's drunk. When I took the picture, his PET scan is normal. If you ask alcoholics why they drink, the number one answer is, I drink to feel normal, I don't drink to get drunk. That's exactly what we see. It's why it's so damn difficult to treat. The alcoholic is drinking to self-medicate the disease alcohol unmasked to begin with. So what you're actually asking the individual to do is stop treating themselves from the disease that got induced by the behavior to begin with. So you can see why it's so difficult to treat. Because for some reason, the brain adopts what's called a positive feedback loop, where the alcohol that produced the disease now becomes the treatment for it. So the manifestation is to continue to use to treat, meanwhile your liver starts to fail. Pot, we'll cut right to the chase with pot because that's what the kids want to hear. We haven't had really good data with pot because it was really hard to get people who just smoke pot. Most people who smoke pot do other things. Well, we hooked up with our friends in the state of Colorado, and we started scanning kids who hadn't smoked pot but started to smoke pot, and that's what we've got. Pot does something that is very unique. It stops brain growth in the only part of the brain that is continuing to grow, the frontal lobe. So during adolescence, the last part of your brain to reach maturity is the front. It doesn't reach maturity until you're 23 or 24. When you smoke pot during adolescence, you arrest the development of the frontal lobe. So the frontal lobe, the part of your brain that's your personality and who you are, stops growing. Now, when you quit smoking pot, it starts again. So it's not an irreversible event. It's reversible, but it's an acute event, which means when you smoke, it's stopped. So if you start smoking pot when you're 15 and quit when you're 25, your frontal lobe at 25 has the density of a 15-year-old. It'll start to grow, and it'll catch up, but it'll take 10 years. So it's a real simple effect. It's a very acute effect, and it's a very region-specific effect. There's an interesting data set that says, because we know that this disease of addiction is one that unmasks during adolescence, we don't find people who are addicted to things that show up at 60 and never used anything until their 60s. You always find that the disease manifests during adolescence. And we think it's directly related to the frontal lobe effect, because if you look at individuals who have never used an addictive substance until after their frontal lobe had developed, so people who never use an addictive substance until they're after 24, 25, less than 1% of them ever get addicted the rest of their lives. So the addictive process, the unmasking of the disease, occurs during adolescence when the front part of the brain is continuing to grow. I always put this slide in because it's the most common question I get when we talk about pot. Kids say, I don't smoke pot, but I go to places where they are smoking pot, and I'm breathing in secondhand pot smoke. Does the same thing. It's no different than secondhand tobacco smoke. Secondhand pot smoke does the same thing. It's dose dependent. The person who's taking a hit on the blunt is getting a much bigger effect than the kid sitting next to him, but the kid sitting next to him is still getting the effect. K2 is spice. It was sold as synthetic pot, and the genesis of it was very simple. People who were incarcerated for substance abuse were released pending urine tests every week, and if a urine test showed up hot, meaning it had THC in it, they were reincarcerated. So they came up with spice. Spice was supposed to be synthetic pot. It doesn't contain any THC. It's 3 compounds that are analogs, but they're not THC. And they get put on potpourri or lawn clippings. There's nothing natural about spice. It is 3 chemicals that are added to plant life. Unlike THC, which is endemic to the plant itself, spice isn't. Spice produces a unique change in brain dopamine by decreasing oxygen saturation in your blood, which simply means you smoke spice, oxygen drops. Well, your brain's Achilles heel is oxygen. Your brain, you can be a boxer, you can play in the NFL, you can use all kinds of drugs, your brain will respond. You start to drop the oxygen, cells die, it's an irreversible effect. What you see is the frontal lobes start to die off first, consistent with personality, paranoia, confusion, and agitation. The classic kid abusing spice develops an acute paranoia and usually becomes aggressive. If you've seen him recently, there were a bunch of kids in a corner in Brooklyn that were all using spice, and they got into fights and became abusive. Cops have trouble with them because they get so agitated. Spice is the classic cause. Molly, ecstasy, I always talk about it because kids always ask me about it and they tell me the same thing. Ecstasy used to be prescribed. It was prescribed in the 70s to young couples who were having marital problems. And the theory was that if we give both man and wife, husband and wife, ecstasy, they'll be able to open up a little more and touchy-feely. Didn't work, but it was used. Kids know it was prescribed. And the minute they hear that a drug is available for prescription, it's safe. Well, even blasting can be prescribed if it's a lethal drug. So ecstasy, aka Molly, raises brain dopamine, but it does it through the serotonin system. Serotonin is a neurotransmitter, like dopamine, that's primary role is mood. People who are depressed have low serotonin. We treat that by giving SSRIs, serotonin selective reuptake inhibitors, to raise serotonin to treat depression. This is serotonin in the human brain. Eyes are right up here. Serotonin is in the same part of the brain as dopamine, but not as much, and in the brain stem. This is a kid who uses ecstasy. Kills serotonin cells. Here is actual tissue. Normal control in the brain. Here's a kid who committed suicide after ecstasy. You can see all the serotonin is gone. Ecstasy is the #1 cause of suicides in high school. It produces an acute depression that is untreatable because you're actually killing the serotonin cells. Kids get depressed. The thing that's so difficult with ecstasy is it produces this incredibly intense depression that we can't treat. Cocaine, this is your brain on drugs, eggs in a frying pan thing. Kids didn't buy it, I didn't buy it. So this is the real deal. This is brain dopamine. Again, eyes are all on the top. Brain dopamine on both sides. You've seen this before. Here's a kid who's 1 month after his last dose of cocaine, 4 months after his last dose. We've looked at him in 11 years, and he looks just like this. The classic cocaine story is one where mom or dad brings the kid to us and says, it's my kid, but it's not my kid. And you push a little further, and I hear 2 things. First thing I hear is, he no longer plays Xbox. She no longer dances. I'm not being sexist, it's what I hear. What it means is consistent with what we see. As you use cocaine over time, years, dopamine cells die, dopamine levels drop. As dopamine levels drop, you lose the ability to feel pleasure from the things that normally gave you pleasure. So if you don't have enough dopamine and you're playing Xbox, you're not going to like your Xbox anymore, so people quit. I hear, she doesn't dance anymore. Well, if she doesn't like dancing anymore, she's not going to dance. I hear, I never see Billy. I never see Mary. I never see their friends. Well, if you lose the ability to feel pleasure from things that normally made you feel pleasure, your friends, dancing, Billy, Xbox, you won't play. So what happens is kids start to withdraw and their world changes. They stay at home more. They're more combative at home. You're not going to see their friends because they're not getting the positive feedback because they don't have the chemistry that allows them to feel the pleasure. It's the classic sign of someone who's using cocaine. The heroin epidemic. We have a lot of data on the heroin epidemic. We know that it was a big cause of it has been the clinical world. The classic line is, people don't get addicted to an opiate in the presence of pain. People get addicted to opiates in the absence of pain. So my daughter comes home from college several years ago and has to have 4 wisdom teeth pulled. They're all in. She gets them pulled in 20 minutes. Looks like she's been hit by a bus. But okay, maybe she needs narcotic pain management for 3 days. Maybe she needs it for 4 days. 4 pills a day, 16 pills. He writes her for 120. Right, so what happens? Everyone knows what happens. You start to take the opiate for pain management. Well, in 3 or 4 days, the pain from having your wisdom teeth extracted, it's still there, but it doesn't need to be managed by an opiate. You can now manage it with Tylenol or acetaminophen, right? But if you continue to take the opiate because you got 120 of them, then what happens? The pain is diminished and you're taking an opiate that's no longer managing the small amount of pain, so the addictive liability starts. So we always tell people the thing that we need to do now is, and you've seen what's happened, we now can't write for 120, thank God. We can write for 5 days. What was happening, and I heard this all the time, you get 60, you fall, you get 60 Vicodin, you take 3 or 4 of them, well then what do? You don't throw them out, you keep them. 1, because you paid for them, I hear this all the time, and 2, it's not a bad idea to have a couple of Vicodin around that for next time you fall on the ice, right? So I hear this all the time. The problem is the addictive liability of opiates exists when you take them in the absence of pain. So when kids go to pill parties, and you can ask your kids about this, and they have to take 3 pills that they have no idea what it is. One of them is birth control, one of them is your dog heart sore medication, and the other one is a Vicodin. This is what's going on. Now, we know that the dosing that's out there, kids can take, heroin addicts that we've seen will take as much as 150 pills a day. Well, if a pill is $25, you can do the math. It gets real expensive real fast. So what happened was heroin came around. Now, in the 60s, heroin was about 4% pure. That meant it was 96% crap. So in the 60s, people who got high off heroin were injecting it. So you saw all the pictures of the drug addicts in the 60s were kids with needles in their arms. Today, heroin is over 94% pure, so most kids snort it. Well, because it's got such a high purity, you don't have to inject it. People start to inject it when they become tolerant and they need to increase the dose. But it's also very cheap. You can get 15 doses for about $4. And you saw on Newsday, front page, you can get it delivered to your front door now. The heroin story is a complicated one, but it's one that's very unique in terms of brain chemistry. This is a normal control, top of the brain, bottom of the brain, 4 levels of the human brain. Top, bottom. This is our heroin abuser. Now you can see that the same thing kind of happens. You get a metabolic blunting, not as great as what you get with alcohol, but a metabolic blunting nonetheless. The other thing that you see is this blue spot and this blue spot. Unique to opiate abuse is the shutting off of something called your opercular cortex. Make this simple. It's the part of your brain that makes you care. Now, we can make this as simple as we can make it. It's, you have an opinion about everything. Your opinion might be that you don't have an opinion. Your opinion might be you like it, you don't like it. But in opiate abuse, what happens is the individual who gets addicted loses the ability to care or ascribe salience to the event. Well, if you don't care about the consequences of what's happened, then that's why when I say to them, look, the next dose is going to kill you because it's got fentanyl in it, and fentanyl's killing more people than heroin. I don't care. Well, look what it's done to your family. I don't care. It's not that they don't care, it's that they've lost the ability to care. So the comparison we make is the kid who transects his spinal cord, and he or she can't walk. They want to walk, they wish they could walk, they know how to walk, they do anything they could to walk, but they can't walk because the connections are gone. That's what's going on with opiate abuse. They lose the ability to care. If you lose the ability to ascribe salience, then treatment means nothing, the consequences of your actions mean nothing, and the consequences of potential treatment mean nothing. This is the last drug I'll talk about. It's methamphetamine. It's the most addictive drug we've ever seen. This is the Breaking Bad drug. It comes in a whole bunch of colors. In its purest form, it looks like ice, hence the name crystal meth. If it's made with red Robitussin, which is pink, there it is. If it's made with triamonic, it's yellow. It shows up in a whole bunch of different colors. It's in every school district. It's the most addictive drug. This is the one 950 to 1.2 million % increase in brain dopamine. This is my daughter, Brittany, when she was 12 years old. This is her brain. dopamine on both sides, bilaterally symmetrical. We've seen this before. And when you're 12, when you're a little kid, you have dopamine in your frontal lobes. This is a 12-year-old girl who got into methamphetamine in her house and she ate it. And she destroyed more than 90% of her brain dopamine. In about 6 months, she developed end-stage Parkinson's, curled up into a ball, paralyzed, fed through IG tube, bathroom through tubes. Her 6-year-old sister's in the same condition. They got into it in their house and they ate it. And they gave themselves Parkinson's disease. Methamphetamine is incredibly neurotoxic. It kills dopamine cells on contact. The comparison here is ecstasy for serotonin, methamphetamine for dopamine. And what happens is you lose dopamine acutely and in huge concentrations is what we started talking about in the beginning, movement disorders. So kids who are abusing methamphetamine are inducing a Parkinsonian-like state. So the thing that's been the most disconcerting is every year we would study people in each drug protocol. And several years ago, the people that we studied in our marijuana protocol kept testing positive for meth. Well, so it turned out that their pot was contaminated. So now what we've been doing is looking at, with our colleagues in DC, the purity of pot. And what we found is that unlike in the 80s, 90s, and early 2000s, where all the pot was laced with PCP, angel dust, it's now laced with meth. And you can go talk to your kids about it because what they'll tell you is kids don't shop their pot. They don't get it where they get the cheapest, they go and get the best. And what they say is the best, they think is, and they tell me all the time, it's THC, because they say to me that the pot that was grown in the 60s was crap. The stuff that's grown today is grown in cat dung, upside down in some guy's basement, hydroponically, and it's got a whole bunch more THC. If you look at the numbers, in the 60s, the THC was about 4.8 nanograms per mil. Today, it's 4.89 nanograms. So there isn't much more THC in pot. What's making it feel and making kids experience it differently are the additives. And the most common additive in pot today is meth. So I've been talking to kids about this for years, and kids say to me, you know what? First, after I heard you the first time, I now take my pot and I dump it out. And I pick the meth crystals out of it. If they're picking the meth crystals out of their pot, the problem's a lot worse than we thought. Methamphetamine is the most common additive in pot. The thing that's the most disconcerting is exactly what you think. Kids don't know they're getting it. Kids don't, they think it's THC. They talk about the concentration of THC. It's not THC at all, it's meth. And if you look at the number in the Northeast corridor from DC to Boston, it's in about 70, depending on what number you look at, 66 to 72% of the pot that gets sampled has methamphetamine in it. Methamphetamine volatilizes too. That means if you're at a place where kids are smoking pot and there's meth in it and it's in the air, they're getting meth too. So I'll end there. I'll answer any questions anybody has. You guys are really good. Maybe you learned something, maybe not. But thank you very much for coming. If anyone has any questions about any drug we didn't talk about, we did talk about. Anyone? Yes. Anyone have any questions? Yeah. Sugar. Right. So, in service of full disclosure, the patient I see the most is obese. Obesity is an addiction to food. So we study addictions, not just chemical addictions. Obesity is number one. Sugar is an incredible addiction. So is salt. But sugar is the greatest addiction. So if you want to, so we've done studies where you can do the exact same thing with the heroin abuser that you can with someone who's overweight. You can show them a food they like. Show the heroin addict a needle and a syringe, and you'll get a huge increase in brain dopamine just from looking at the cue. And it's so specific, we've done this. You can find out what they really like and what they don't like. And the one who likes bacon, you show them bacon, you get a big increase. They don't like Brussels sprouts like me, you get a decrease, right? So sugar, absolutely. Absolutely. Yeah? Yeah.
What's the main difference between cigarettes and e-cigarettes?
Right. So the question he asked is, what's the main difference between cigarettes and e-cigarettes? So when we talk about cigarettes, they are contain tobacco, the brown plant. E-cigarettes contain no tobacco. Instead, they contain the liquid that has nicotine in it. So the difference between the two is cigarettes contain tobacco, you lose your monoamine oxidase. E-cigarettes, no tobacco, you don't lose your monoamine oxidase. Yeah. So the liquid, you buy the liquid that has nicotine in it. You buy the liquid. Well, it's synthetic, yeah, it's made synthetically, but it's added to the liquid that you put in the cigarette, or a cartridge.
Also, they're adding the meth to make it more addictive.
Correct. Correct.
So, how do you feel about legalizing
Right.
property? I mean, if it wasn't placed with the meth,
Right.
it would be.
Absolutely.
It's
So
still
did you hear the question? So she asked, the classic question is about legalizing pot. So it speaks to that question directly. If I could go buy pot at CVS, then the pot I bought at CVS wouldn't be contaminated because it would be inspected and got right, so no contamination. If you go and look at the state with the highest contamination rates of pot, it's Colorado. Because you buy it, you go to the CVS, you buy it, you lace it, and you resell it. Now, the people who you resell to would rather buy from you because it's a better pot than the stuff they got at CVS. Right? So people have used the argument all the time, we should legalize it because then it won't contain. Yes?
Suggestions on how to increase communication between parents, children, children, parents.
Right. Here's the million-dollar question. What do we do? How do we? I think you have to educate. I think you have. I mean, one of the things I always say this. I wish you could come with me when I talk to the kids because they ask questions. We couldn't answer them all, right? We had to stop because they were. You have to educate. Kids don't know, and the stuff they do know, they have wrong. So, I think you have to educate. I think you have to speak to them, and you know, your parents. Kids are really good at knowing when you're BSing them. You can't BS them. You got to make sure you tell them because they'll find out if you don't. Right. So I think you got to educate. I wish I could tell you that it worked for me. My son got kicked off campus his third year in college for underage drinking. So I wish I could tell you that my way worked. It didn't. But I think you have to educate. That's my thing. Just talk to the kids and let them know what's going on. I don't know what else to. I get asked it all the time. Talk to the kids. Yeah.
You said that if the marijuana has meth in it,
Yes.
and I bought a drug test at CVS and drug tested my son, would meth come up positive?
Yes.
Oh, it would. Okay. Thank you.
Yeah. So chewing tobacco, right. So the question is, what about chewing tobacco? So it comes down to route of administration. Generally, people who chew tobacco get a higher dose of nicotine than people who smoke it. So chewing tobacco becomes really addictive. And the dose per unit volume is higher in chewing tobacco than it is smoked. So chewing tobacco gives you a higher dose. Yeah.
I'm not sure if I understood the whole frontal lobe development. Were you saying that if you get past, say, the frontal lobe development without addictive exposure, you pretty much run
Yep.
a better chance of not?
You won't get addicted. Right. Absolutely.
And that's about 25 or?
Yeah, it's like 23 years in a girl and about 25 in boys. Yeah.
The THC that's in, the liquid that's in the cartridges.
Yes.
That's also being contaminated as well, and the kids don't know where they're getting that.
Correct.
Is there a different impact to them because of the conveyance method?
Right.
As opposed to smoking something?
Yeah, so the question she's asking is, so one of the things that's unique, so we'll make this real simple. The temperature at which a match burns, so a lit blunt, is much higher than the temperature that a vape burns. Because a match burns hotter it destroys more of the compound, all the compounds. Because a vape has a lower temperature of combustion, it becomes more efficient, meaning you get a higher dose in a vape than you get with a lit blunt. So people who are vaping nicotine are getting a higher dose than if they smoked a joint with THC in it. Vaping gives you a higher dose because it's got a lower energy for combustion, which means it becomes more efficient. And you can talk to kids. They'll tell you that what they do is they wax. You all heard of waxing. Where they'll take, in our day, it was Thai sticks, hash. Now they make wax out of it. You all know they distill it in butane. You get butane? Anyway, they put that in vapes, wax, because wax melts really efficiently under those coil heats, and they get huge doses of THC. Huge. Not that we've seen, because usually it's distilled in butane, which means that you have to make it in butane, and they don't. We've not seen meth in the wax concentrations that we've looked at. Yeah.
The difference between e-cigs and regular cigarettes, they both have nicotine, which suck the oxygen out of your blood, right? But the cigarette has tar in it.
Yes.
And that's the carcinogen?
Absolutely. So that's exactly what we see. People who smoke tobacco products, about 500,000 die every year, 450,000, from tar and CO-related diseases that vapes don't have. So kids will always say, vaping is safer. If safety is death, it's a lot safer. Right? If safety is you're not going to die, absolutely, it's a lot safer. The question is vaping going to increase the likelihood of addiction to other compounds faster than tobacco? And it looks like, initially, it looks like it is. But safer? Absolutely, vaping is safer if safety is death, yes. Difference between I still couldn't hear it. Oh, blood test and a urine test. One is done with a red liquid and one is done with a yellow. So the difference is usually sensitivity, which means we can detect compounds at lower levels in blood than we can in urine. Urine is a waste product, so the metabolism. Let's make it simpler. We can usually see drugs at lower doses in blood than we can in urine.
What about the hair?
Right. So hair is the classic, right? Because hair we can see for as long as your hair is, we can see the constant. So with hair, we get a drug history. With a blood test or a urine test, we find out acutely if you've been using. With hair, we can see how long ago. Yep. Yes.
What's the effects of Adderall and the mixing of other drugs?
Right. So the rule of thumb when you mix compounds is, so let's make this real simple. Caffeine will raise dopamine about 100%. I'll just use simple numbers. Caffeine, 100%. Nicotine, 5,000%. If I drink coffee and smoke a cigarette, it's not 100 plus 5,000, it's 100 times 1,000. So it's logarithm, right? So whenever you add another drug, when you have two addictive drugs, they're synergistic. Now when you add Adderall to alcohol, which is common, the numbers so Adderall will raise dopamine levels about 600%, but it'll do it over days. So the one thing we didn't get into is not only is the magnitude of the effect matter, but the rate. If I raise your dopamine levels 5,000%, but it takes me a year, you'll never get addicted. The problem with addictive drugs is it goes up 1.2 million times in 8 seconds. So if you do Adderall, which is about 600% if you take it PO, and a shot of alcohol, which is, let's make it 10,000%, now it's about 600,000. So whenever kids who are on Adderall, using Adderall, if they drink, it becomes a real issue.
You're saying that ADHD
$1 million question. So the school of thought, so the question she's asking is, how do we know when, in someone who's got Adderall, so when someone who's got ADD or ADHD, when their dopamine levels are normal? So what we do is we've looked at the rate, so because we can measure dopamine, you can look at the rate of decline. You can look at a 6-year-old and look at his dopamine, you can look at a 90-year-old and see his, and look at a 50-year-old. You can draw a pretty linear line. So you can pretty well calculate where your dopamine level should be based on your sex and your age. So we know what normal is. So we know that typically the rate of decline in someone with ADHD is about 5% less with the disease. So we know that by the time they're 18 or 19, mathematically, the decrease that they are going to get as a consequence of normal aging reaches the level that they are with the disease. So all of a sudden, the number that was low and they had ADD is now normal because they've gotten older. We think that's around 18 or 19. So if you look at, now you go and look at people 18 or 19 years old and their dopamine levels are all normal, even if they had ADD or ADHD before. So we kind of go by age. And the problem is, I mean, you guys know the problem. People leave school with their meds. The minute your dopamine level is normal and you take a drug that raises it.
Do they ever use a PET scan to pinpoint that amount of dopamine?
Not yet.
And to change the medication?
Yeah, we do, but not yet. Not yet. Yes.
You spoke about gateway drugs and, what is and what may not be, and you talked about caffeine being
Yes.
effectively a gateway drug, but there has to be a correlation between nicotine and THC as a gateway, both, not only physiologically, but obviously there's all the psychological component to it. What have you seen?
So you're asking me, are nicotine and THC gateway drugs? Right. So when people talk about gateway drugs, it really comes down to the definition. And all that means is you go, if it's a gateway drug, then what that should mean is some huge percentage of, so now we go look at illicit drug users. We'll go look at people who are heroin abusers. That you go and you look at the heroin abuser and most of them tell you they started out with pot. Well, in fact, they don't. Most of them don't tell you they started out with pot. So that kind of flies in the face of, well, then maybe it's not a gateway. More of them start with alcohol. Well, so then you look at, well, is alcohol a gateway drug? But now you go and look at the differences in rates of the abuse of the two drugs, and one doesn't necessarily predict the other. There are a lot more alcoholics than there are heroin abusers. So the whole gateway thing becomes tenuous at best. So what we do is we look at what's the commonality? What drug have the methamphetamine abusers all have in common? And the thing that is the most in common are inhalants. Get high. Used to get high. Right, we have patients who get high on gasoline, drink gasoline. Right, you saw front page of the New York Times Magazine 2 years ago. Whole big article on in the southwestern United States, their biggest drug of abuse is gasoline. So inhalants is the greatest predictor. Now, if you want to say people who smoke or people who drink, the people who smoke pot, have a higher likelihood of substance abuse, absolutely, they do. But it's not, it doesn't kind of meet the classic gateway discussion is always what drug is common? What is the drug that is the most common to people?
Can the PET scan measure medicine resistance?
Yeah, it's a good question. So the question she asked is, can the PET scan measure medicine resistance? So I think what you're getting at is, if you look at the disease of depression, we give people SSRIs to treat it. Well, there's the 1/3, 1/3, 1/3 rule. 1/3 get better, 1/3 don't, and 1/3 get worse. So in a perfect world, I would like to, if you are depressed, I'd like to be able to give you a PET scan and say, based on your PET scan, that drug's going to work. It'd be great if I could use PET to show me which drug's going to work on you better. We're not there yet, but we are now at levels where we can see what drugs get to the part of the brain we need them to get to and at what dose. And one of the things we learned was in the disease of schizophrenia, we give drugs called neuroleptics. Well, that just means we need to bind up all the dopamine receptors. The doses we're giving people are hundreds of times too high. Because we see with a PET scan how many, we can see how much of a drug binds. We know how many dopamine receptors there are. We know the potency of the drug. We know how much it should bind it all up. So if I give you 1 milligram and it binds up all your receptors, or I give you 50 milligrams, so what PET's letting us do is letting us dose better, but we're not yet to a point where it lets us look at the efficacy better.
You know, they do the DNA test.
Uh-huh.
Where that points out that it's, I think, how you metabolize the drug or
Yeah.
something. But again, over time, there's no way to measure that.
Not yet.
No, and that's
We can look at,
critical, isn't it?
it's critical.
Yeah.
Yeah, because what games do we play? People come to us that are depressed and we give them drug A. And 6 weeks later, they come back, it's not better, we give them A plus B. And 6 weeks later, they come back and we give them 3 other drugs, we take A off. Yeah.
So what does one do?
Yeah, well, has anyone around here got an answer? You hope that we come up with better ways to look at drug efficacy as a consequence of drug binding.
Is there any tests that can show a genetic predisposition?
Right. So the question she asked is, are there any tests that show genetic predisposition? None that we've seen. We know that there's clearly a genetic predisposition to alcohol. If you look at alcoholism, it's about 30%. The kids born of an alcoholic parent, single parent, about 30% of them carry the gene for alcoholism. Doesn't mean they're going to express, it means they're carrying the gene. We're not, with other drugs of abuse, we haven't seen it. The only exception to that are every hour of every day, 2 kids are born in the United States addicted to opiates. We know those kids have the highest likelihood of becoming substance abuse. But the answer is no, not yet. Right. So how do you get high on Sharpies? It's a really good question. So Sharpies, so when I was a kid, so the people my age, do you guys remember those mimeograph machines? They'd sit there and crank it and the blue sheets would spit out, and we'd huff the blue sheets because that was hexanes. So Sharpies have compounds called VOC, volatile organic compounds, like gasoline. When you go to a gas station, you smell gasoline because it's volatile. So kids get high on Sharpies because they're getting hexanes and xylenes in the air that cause membrane fluidity in your brain, which gets you high. So they're getting high off the volatile compounds, the gases that are in the Sharpie. And the way they do it is they put it in a plastic baggie. They put 3 or 4 of them in there, and the gas concentration builds up, and they breathe off the bag. It's really common.
Which activities are recommended to have someone have the most balanced dopamine serotonin level?
Yeah, it's a good question. Right. Right. So the question is, how do we maintain normal dopamine serotonin levels? So the thing that we've seen that's been the most effective way to get dopamine levels back to, you never get them back to normal, but back a little bit, is people who exercise. So remember, there are people, we see people who are addicted to exercise, right? They get euphoric on a treadmill, which simply means it raises dopamine. People get euphoric because they get a huge increase in dopamine. So the only thing we've ever seen that kind of brings dopamine levels back to what's normal are exercise. The only exercise we've ever looked at was treadmills. So I think an exercise routine probably makes dopamine levels fluctuate less around the mean. Yeah.
Quick clarification on SSRI, Adderall, and amphetamines, they're all the same?
No, they're different. So an SSRI, serotonin selective reuptake inhibitors, bind to serotonin transporters, a receptor here. Adderall binds to dopamine reuptake sites, a different protein here. And what was the other one? Amphetamine. Right. Binds inside the cell, causes dopamine to be released. So all 3 drugs bind to 3 different molecular sites and produce changes in the neurotransmitters differently. SSRIs increase serotonin. Adderall increases dopamine by transporter blockade. Methamphetamine increases it huge by causing dopamine dumps.
And just one quick follow-on, I was a little confused because you said that using Adderall and alcohol magnifies.
Huge.
But I thought Adderall was an upper and alcohol was a downer, so shouldn't they be offset?
Right, they don't offset because alcohol decreases membrane fluidity. So the way to think about this is alcohol facilitates the transport of methamphetamine or Adderall into the brain, so you end up getting a bigger dose. Yeah.
Either like the current combinations, they have an effect on the longevity of the dopamine effect in the brain. So because some things, have to 24 to 36 hours, if you were having Red Bull, vodka, is that window?
It makes the window longer. It increases the length of the window. Right. So if you do, you look at alcohol, shot of alcohol, 5 to 7 days. A shot of Red Bull and alcohol, 9 days. 7 to 9 days. Just because of the dosing. Yeah. Same thing. So Molly and ecstasy are the same thing. If you want to look at a drug that's got the highest impurity, it's Molly. Molly has the highest, because it's pure. So if you look at a tablet of Molly, it only contains about 6% MDMA, because if it was 10%, it'd kill you. Molly is Molly. Same thing. Molly stands for molecule. Yeah. E, they call it E.
So then when someone is taking any type of the substances that you mentioned, there are varying degrees of increase of their dopamine
Correct.
Levels, exponential.
Correct. Absolutely. Right. 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 It's a really good question. So did you all hear the question? So it speaks to what we hear all the time. I'll see people who in their 60s, 70s, who smoked for 20 years, quit in their 40s. So they haven't smoked in 30 years. But they'll still tell me, man, every so often I really crave a cigarette. I hear it all the time. So the answer is the data that we have suggests that as you use addictive drugs, you lower your brain dopamine. The consequence of lowering your brain dopamine is craving. Now, what happens? Eventually, your brain adjusts to the level of dopamine you have. So you crave less. Craving doesn't go away, you just crave less. So the theory is that you're better able to manage the cravings than give in to them. So people we see all the time will say, I'm fine unless every so often, and it's usually associated with a cue. Every so often I have a really bad craving, even though I haven't used in 20 years. So what happens, what we think is you adapt. So consider the alcoholics I showed you, the guy in the middle who's if he walked in here, you wouldn't know him from anybody because he's living a perfectly normal life. His metabolic rate is a third what it should be, but his brain's adjusted to it. So what we think in the craving thing is craving doesn't go away. People will still crave 40 years after they use the drug. They manage it. Yeah. So steroids are addictive. Anabolic steroids are addictive. The big thing with steroid, they produce an increase in brain dopamine. The big thing that's really the difficulty with steroids are the cardiac effects. Right, so we're here talking about CNS effects, brain effects of all these addictive drugs. Steroids, they have CNS effect, brain effects, but their biggest effects are cardiac. People get their heart gets enlarged. They get a hypertrophied lung, a hypertrophied left ventricle, which starts to fail, go into VTAC. So the steroid thing, we see a lot of it, is cardiac. The dangers are more cardiac than anything else. Yeah. Yes. Was in a. So that's what we do. That's how we treat people. We put them in a rehabilitation place where there are no cues. Yeah. Right. Right. So the question is, so she's asking the $1 million question, and that is the impact of environmental cues. So what I didn't show you in that study, just to save time, was we reproduced it. We did the study again, the coffee study. We did it again, but this time we told them they were going to smell coffee. This time we said, 2 minutes into the scan, you're going to smell coffee. No effect. Didn't activate the accumbens. Meaning, if they know the cue is coming, the significance of the cue is nothing. The problem is, and it's not a surprise to anybody, the cues that they get hit with, they don't know that are coming. You know, they walk by a bar and they see it off the corner of their eye. Or they run into their friend. They didn't know they were going to run into their friend. So the trick is you've got to get them to be aware of the potential cues. And if you're aware of the cue, then you can become, the impact of them becomes decreased. So what they've looked at, and so what we do at Seafield is we try, one of the things we teach is cues. You need to be aware of the cues. Tell me where you use. Well, let's talk about what cue, right? Yep. If you're aware of it, so the key to the cue is the surprise. When they're sitting in the camera and then all of a sudden they smell coffee, you ought to hear them. You ought to hear them. Oh my God, is that Starbucks? Is that a venti star? You know, yeah. Absolutely. Smells are the worst. People are in the second. Right. Smells are the worst. When I was a kid, my mom would you guys know what Vicks is? When I was a kid, my mom used to put, when I'd get a cold, my mom used to put Vicks on my chest. I don't know where the hell that came from. When I smell Vicks, because so with ecstasy, kills serotonin. Serotonin helps regulate your core body temperature. So kids who die of ecstasy because their core temperature goes up to 106, and it kills them. So they do two things. They preload with huge bottles of water. So if you ever see your kids going out to a party and you see he or she is drinking liters of water, they know that the more water you get in, the better you can thermoregulate if you use ecstasy. And two, Vicks dissipates heat. So if you cover yourself in Vicks, you can thermoregulate better. So kids will cover themselves in Vicks. Ask them. Well, so I smell, kids will come in and they smell of Vicks. Every time a kid comes in covered in Vicks, I see my mother coming down a hall with that little green bottle and a towel. So yeah, smells are the worst. Anything else? Yes. Right. Doesn't regenerate, it adapts. So remember, one of the ways to think of it is you have a dopamine level here when you're 5 years old and you die here. And you live a normal life with this linear decrease. When you use a drug, you introduce a step function into that linear decrease. Instead of having a nice linear decrease, you're going down, you use a drug, and you drop. So now you're at a place, you should be here, but you're here. Well, you were going to get here anyway, which means here can be normal. Your brain just needs time for it to be normal. So what we can see is we can see where you are based on your age, where you should be, where you are, and we can tell that difference. So some drugs produce changes that are reversible. MAO is the classic. It's a reversible effect. But every drug we've looked at produces a change in dopamine that's permanent, but the brain can adapt to it. Yes. Well, so what do we see? So we see higher incidence of depression. So depression is, we typically think of depression as low serotonin, not low dopamine, but they kind of go hand in hand. We can give dopamine drugs to make you feel better. Um, so you see, so what do you see? In substance abusers, you see higher incidence of movement disorders, lower brain dopamine, higher incidence of depression, consequence of serotonin related to dopamine, higher incidence of suicide, higher incidence of cognitive dysfunction, which means so the opiate abuser or the alcoholic who's really been using for a long time will have a decrease in cognitive function as a consequence of the change in acetylcholine secondary to dopamine. So yeah, we see all the changes associated with dopamine. Yeah. Yes. Right. So the biggest change we see in the CN, in the brains of steroid abusers are vascular changes. So they get vascular accidents. They'll get small little infarcts, mids. They'll get small little strokes. So the biggest change we see in the brain. So we see a couple things. We see change. So steroid receptor, the highest concentration of steroid receptors in your brain is in a part called the hippocampus. Hippocampus is a part of your brain that's responsible for updating memories and spatial orientation. So people who are abusing steroids have trouble reprocessing and re-updating a memory because of steroid abuse. So you see a unique cognitive decline as a consequence of steroid use. They can't, believe it or not, we update memories all the time. Right, you'll remember something today, and in a month you'll remember it a little different because it hasn't been updated in time. You've forgotten the little things, so memories fade with time, and to the point where memories completely change. What, she was there? I didn't remember her being there. I remember everything about it. I didn't know she was there. So what you see with steroid abuse is changes in the ability to update a memory. That means things you can't remember all the events you used to be able to remember because you impacted the thing called the hippocampus, which is specifically responsible for updating memories and spatial orientation. That means so everybody in this room can tell me the shape of your house, the shape of your bedroom, because everyone knows from your hippocampus your three-dimensional space. If you start to mess with the hippocampus, you won't remember if your room was round, rectangle, is it flatter than it is tall? So we start to see changes in the ability to update memories of the hippocampus in steroid abuse. Yes. It is. Yep. So the hippocampus is impacted by alcohol profoundly because alcohol binds to, right, so you get cognitive changes in spatial orientation. Absolutely. Yes. Right. So I was a board member. I have my classic board story. Way back when, we used to see report cards from the elementary schools back in the 90s where the teacher wrote, Johnny's a good kid, these are his grades. Little disruptive in class, recommend Ritalin 40 milligrams BID. So back then, and in court, I'm not a board member anymore, but I can. If you want to look at correlations, Ritalin use correlated with class size. As classes got bigger, it was easier to medicate kids than it was to not medicate. So back in the 90s, it was overwritten. Everyone was getting Ritalin. Then, just as you would guess, the pendulum swings back this way, and now no one was getting it. I think we've gotten back to a point where it's probably underwritten a little bit. But yeah, we've gone through both of those swings. Back in the 90s, they were putting everybody on it. Now it's less. Right. Why can't we make dopamine? It's a really good question. Because the brain is a really fascinating thing. It lives to control itself. So you have this blood-brain barrier which limits things it can get in. Because, so you can think of it this way. If I was able to manipulate dopamine by giving it to you, then I can take it away. I can give you Parkinson's disease. I can do that anyway by giving a drug that takes it away itself. Or I could increase dopamine and make the brain more euphoric. Euphoria is not a state that your brain wants to be in because it's not consistent with sustaining life. If people were high 24/7, they wouldn't, work and do whatever. So the brain is really good about controlling. It's called homeostasis. So there are all kinds of theories about why we can't get drugs into the brain. What we can do, we can give drugs that open the blood-brain barrier and give dopamine. We can do that. I can give you mannitol. I can give you a drug that opens your blood-brain barrier, give you a shot of dopamine, and it'll get into your brain. The problem is I can't open your blood-brain barrier just to dopamine. Once I open it, it's open to everything. So now all of a sudden, all kinds of things are going to get in that shouldn't. Yeah. For caffeine. So it looks like it's a couple hours. Looks like it's a couple hours. So the question she's asking is the time course and the effect of caffeine on the blood-brain barrier. It's right. It's a dose-dependent effect, and it's a history of exposure effect. The more coffee you drink, the longer it lasts. So people who are drinking coffee every day, their blood-brain barrier is leaking, for lack of a better word, continuously. Right. Yes. Can it be extracted? Yeah, it can. We don't do it, but it can be. Yeah, we can extract it. We can take pieces. So people who have brain tumors, that we take the brain tumor out, we can extract all the dopamine out of that brain tumor. Yes. Yeah. Meth. So we've seen, a single dose of meth can cause a 20% loss in brain dopamine at the single dose, permanent. Single dose. Number 2 would probably be ecstasy. Ecstasy's really bad, and it's really common. Do you have enough? Thank you, guys. Thanks.